Do you want X-ray vision? Same. No, not in a creepy way, just in a way that would allow me to see the inside of someone's oropharynx and esophagus when they eat and drink. Okay, that might sound creepy to the average person, but as a medical SLP, you get where I'm coming from. The truth is, we can't actually see a swallow at bedside, which is why instrumental swallow studies are so important. But I get it, not every facility has access to them. So what's an SLP to do when instrumentation for swallow assessments isn't always available? We need to prove the value of instrumentation to the decision makers. We need to educate them. Then we need to consider their perspective. Keep watching if you want to learn why and how we should advocate for instrumentals for your dysphagia patients. Let's dive in.
I'm Teresa Richard. I've been a medical speech pathologist for 15 years. I'm a board-certified specialist in swallowing and swallowing disorders. I'm the founder and CEO of the MedSLP Collective and MedSLP Education.
Number 1. Bedside swallow evaluations don't see the whole picture, and research proves it. According to McCullough et al. In 2003, the subcommittee on the clinical swallow exam reported, based on over 150 articles, that while data supported with some dissent the use of CSE measures to detect aspiration post-stroke, no data existed to support the use of the CSE to evaluate any of the physiologic measures deemed necessary for complete examination of swallowing function. That's 154 studies at the time of this report, which was in 2003, which is 20 years ago. That's 154 studies 20 years ago that found no data to support using the CSE to evaluate swallowing physiology. Do you know how trusty your clinical skills are at the bedside? According to a 2002 paper published by Leader, 70% of the time you are overdiagnosing your patients with dysphagia. At the bedside, without any sort of instrumental, 70% of the time you are using clinical signs and symptoms to create a diagnosis that doesn't exist. Runny nose, not correlated. O2 stats, not correlated. Also, according to Leader in 2002, SLPs are also pretty consistently missing silent aspiration at the bedside as well, as in 14% of the time. Why should it matter if we miss silent aspiration? Aspiration pneumonia is the leading cause of death in nursing homes, and residents that are diagnosed with aspiration pneumonia have a mortality rate 3 times higher than the other residents. Okay, so what's ASHA's stance on needing instrumentals? Per ASHA's Adult Dysphagia Practice Portal, the clinical examination may inform recommendations for the management of dysphagia, including identifying clinical presentations of dysphagia, identifying potential risks and benefits of initiating or modifying oral intake, for example, risks of dehydration, malnutrition, determining the need for additional instrumental evaluation, and specifying diagnostic questions to be answered by instrumental evaluations. To quote ASHA, who cited Garand and colleagues in this quote, "The non-instrumental assessment of swallowing is insufficient to infer specific information about laryngeal, pharyngeal, or upper esophageal anatomy and physiology required to develop effective treatment options and prevent consequences of dysphagia, such as dehydration, malnutrition, pneumonia, and death." I don't mean to say all of this to come off as alarmist or to scare you. I think it's important that SLPs are aware of what our governing body and published research say when it comes to dysphagia assessments and the roles of instrumentation. But does every single patient need an instrumental exam? Per ASHA's Adult Dysphagia Practice Portal, indications for an instrumental exam include the following. Concerns regarding the safety and efficiency of swallow function, especially if the dysphagia is contributing to nutritional compromise, pulmonary compromise, or concerns of airway safety, like choking. When there's a need to identify disordered swallowing physiology in order to guide management and treatment. We need to be able to target specific areas of weakness or impairment, which can only be confirmed through instrumentation. Instrumentation is indicated when there's a need to assist in the determination of a differential medical diagnosis related to the presence of dysphagia. In the presence of a medical condition or a diagnosis associated with a high risk of dysphagia, instrumentation is indicated. When there's previously identified dysphagia with a suspected change in swallow function, instrumentation is indicated. And finally, instrumentation is indicated in the presence of a chronic degenerative condition with a known progression or the recovery from a condition that may require further information for the management of oropharyngeal function. Here's an example of why instrumentation is important, a case study. A patient with a history of a right MCA stroke had an NG tube in place and had been NPO for 4 months. At her sniff, her NG tube was dislodged and she needed it replaced, so she was sent to the hospital. Before getting her NG tube replaced, speech therapy was consulted. The SLP completed a VFSS. The patient's swallow was normal. There was no need for the NG anymore. So what happened at the sniff? The patient had remained NPO at her facility because she was coughing and getting a runny nose every time she tried food or liquids. As a result of her SLP's clinical swallow exam, this patient remained NPO for months, unnecessarily. This patient had a history of chronic cough and gustatory rhinitis. Her coughing and runny nose were not a sign of aspiration. There was no way to know that for sure without an instrumental. This is a story that many of us have lived through as medical SLPs, including myself. I share these stories to show real-world examples of why instrumentation is so important. Never to speak poorly of other SLPs because we are all here to learn and grow together. I made plenty of diet recommendations from bedside swallow evaluations back when I first started out, and I just wish I knew then what I know now, which is why I'm here today. Number 2, just put them on thickened liquids or just do your best at the bedside is not the answer. All right, so now that we're all on the same page, you need a VFSS or FEES to properly diagnose dysphagia. Maybe you're getting pressure to just give them thickened liquids or just do your best at the bedside by your DOR, administrator, or a doctor who is resistant to instrumentals. We're going to dive into the exact numbers you need to refute these arguments. We have an entire video on the pros and cons of thickened liquids, by the way, titled, "What are the benefits of thickened liquids? The pros and cons of thickened liquids." Okay, so save these numbers for when you speak with your DOR or administrator. Thickener itself does not directly cause dehydration. However, according to Daniels and Huckabee, patients have a tendency to find thickened liquids not as palatable, therefore drinking much less than if it were a thin consistency. What happens when you don't drink enough fluids? The patient is at increased risk for dehydration, malnutrition, electrolyte imbalance, sepsis, and/or a UTI. Okay, so those are all no biggies. So what's the hype? Well, the hype is that all 5 of those conditions account for 78% of all 30-day rehospitalizations, according to Moore and colleagues from their 2010 paper. Each time a patient is rehospitalized from a sniff within 30 days of their previous discharge, the sniff is responsible for footing the bill. So those 5 conditions can potentially cost a facility an extra $30,000. Each of those conditions has been deemed as potentially avoidable with careful monitoring of and adherence to patient fluid and nutrient intake, and by following appropriate positioning of residents with swallowing difficulties to avoid aspiration that could potentially lead to pneumonia. The cost to keep one resident on thickened liquids for 1 year can cost a facility between $2,000 and $7,000. Really doesn't seem like a huge deal to downgrade someone to nectar thick liquids, but when you consider the cost for the entire year, because you may just discharge them on that consistency and never reevaluate them again, and also consider the increased risk of various medical conditions that can turn into a rehospitalization, then getting an instrumental first just to be sure that they do in fact need the thickened liquids really truly is the way to go. Otherwise, you could be costing your facility more money in the long run, hurting your patient, not helping, and with a 70% chance that you are overdiagnosing at the bedside. That's a pretty high likelihood. And as I've stated in multiple posts online, I am by no means against thickened liquids. I'm all for using them as they are intended to be used, just not as a catch-all solution. So those are numbers related to thickener, but what about tube feeding? According to Huang and colleagues, the cost of managing a patient with a feeding tube, which for many has been the primary treatment option for dysphagia, is reported to average over $31,000 per patient per year. Okay, but instrumental exams cost something too. Won't facilities refuse to team up with mobile FEES companies, for example, because it's an added cost? Well, let's look at how much a VFSS or FEES costs. Depending on the company, instrumental swallow studies can cost anywhere from $250 to $500 per mobile swallow study. That's a lot less than the cost of thickened liquids or PEG tubes for a year, or even a few months. One common experience among medical SLPs is the pushback that management gives to instrumental assessments. This was perfectly exemplified in one incredible discussion thread you can find inside the private MedSLP Collective Facebook group for our members. One member posted a question to seek guidance on how to approach management, who questioned her clinical process for bedside swallow evaluations and instrumental assessment recommendations. In this case, the rehab manager was telling this SLP and her team to rely on the bedside assessment for diet advancement because they were ordering too many VFSs inappropriately. Yikes. This SLP and her team had already voiced concerns about the lack of reliability with bedside assessments. However, this manager's response was along the lines of, well, if anything happens, at least they're in the hospital, the best place for it to happen. Oh boy. This SLP and her team were looking for support, so she asked the mentors and members inside the collective what they would do or have done at their facility if they've experienced this similar level of pushback. And wow, did the responses come flooding in. Here's a breakdown of the suggestions they provided her. Pull case studies in dysphagia malpractice litigation to show actual legal cases that could be referenced regarding diet recommendations at bedside without an instrumental exam. One book titled Case Studies in Dysphagia Malpractice Litigation by Dennis Tanner was recommended. Share how instrumentals can save the hospital money. One member commented that she has argued that hospital-acquired aspiration pneumonia costs the hospital between $10,000 and $15,000. This can include the cost of increased length of stay and hospital readmission in under 30 days. Several people also shared an editorial reviewed resource we have in our collective library called How to Talk with Your Team About the Evidence. This discussion thread alone became a goldmine of tips and perspectives to help advocate for instrumental swallow studies. I'll be posting other videos just like this one that you won't want to miss, so make sure to hit that like and subscribe button and turn on the notification bell. Also, do you have any specific questions about how to advocate for VFSS or fees? Leave a comment below and tell me about it. We'll be sure to get your questions answered as soon as possible. Make sure to stick around to the end to claim a freebie or two. This particular freebie could be extra helpful for you if you're up against colleagues who question your evidence-based practice when it comes to dysphagia and instrumentation. Number 3, what to say or do to get your DOR or administration on board. All right, now you know why instrumentals are necessary and you have the data and financial numbers to back up your claims. It's time to meet with the decision makers. If you're in a SNF, this likely means your DOR, DON, or some other administrator. Here's what I suggest you do when it's time to set up that meeting. Understand your boss's point of view. From their perspective, SLPs have been using their best clinical judgment at the bedside for years without issues, right? They're thinking, you went to grad school for this and have no idea why you need a fancy VFSS or fees when SLPs in the past have never needed them before in order to do their job. The administrators work for a business. Part of their job is to save the facility money because the facility can't have any residents if it's broke, right? Your boss needs to fully understand why VFSS and fees are 1, necessary to do your job and patient safety, and 2, will actually save the facility money in the long run. Now is a good time to pull out those numbers we crunched earlier. You know, the ones about the cost of thickened liquids and PEG tubes versus the cost of VFSS and fees. Make sure the timing is right. Your boss is likely juggling a lot of things. The DOH is coming, there's an outbreak of C. diff, there's a demanding family, there's a pandemic. Be respectful of your boss's time and ask to set up a quick 10 to 15 minute meeting instead of barging into their office unannounced. You can also bring coffee or whatever treats they might like. Everyone likes to feel appreciated and cared for after all. Keep working to build relationships in your facility. In addition to your DOR and DON, there are even more people to recruit to your instrumental support squad. The RD, billing office manager, patient and their family, even the marketing director can all be a part of advocating with you. Stay confident and keep gaining respect in your facility. Remember, you're an SLP who treats physiological problems with swallowing. Watching patients eat and making sure they tolerate their nectar-thick liquids before you discharge them forever is a thing of the past. Show off how really smart you are, and again, this will help explain why you really need instrumentals to do your job. For example, you could explain that due to the right CVA, we're seeing some impairments with XYZ muscles. We're working on the Shakir, Mendelsohn, CTAR, and we're using NMES. And instrumentals recommended to confirm that our treatments are improving the underlying physiology. Once that's confirmed, we can possibly upgrade the patient back to thin liquids. This is my ultimate goal since she did present with a UTI in the hospital as well. We really don't want to risk another rehospitalization. How much more compelling is that than just saying you recommend a VFSS or fees? We recently had a member of the MedSLP collective share a win that was about getting buy-in from the higher-ups in her facility when it came to scheduling instrumentals. Despite the fact that her facility already had mobile fees contracts in place, there was still pushback due to cost concerns. Well, she decided to do some education. She took the evidence-based information she had collected from published research articles and put together an in-service to discuss the research, best practice, the benefits of instrumentation, and cost effectiveness. The result? She was given the green light to schedule fees for a patient her DON and the executive director were really pushing back on. Not only that, but the fees showed how much the patient's swallow had improved, and she could advance the patient's diet to thin and solids. further saving the facility money on costs of thickener. This is the perfect example of how education, research, and open discussions about cost effectiveness can strengthen your advocacy efforts. If you'd like to learn more about how to have discussions with your team about the evidence in hopes of getting more buy-in for instrumentation, then I have a free gift for you. You can download one of our most popular resources titled How to Talk with Your Team About the Evidence. This is a resource you can find inside the MedSLP Collective library. If you find it useful, then I invite you to check out our membership for more resources like it. The link to this freebie is in the description below. We have a robust and vibrant community of SLPs and mentors to help you out with your toughest clinical cases. Head on over to www.medslpcollective.com to learn more.